Hi, my name is Amelia Poquette. I will be presenting on our project entitled Hyperthermic Intraperitoneal Chemotherapy for Advanced Stage Ovarian Cancer Does Not Complicate Post-operative Recovery. Following a widely publicized study in the New England Journal of Medicine in 2018, it was shown that adding HIPEC to interval debulking surgery, which I will hereon call IDS, improved ovarian cancer disease outcomes, including length of recurrence-free survival and overall survival. As HIPEC protocols are adopted, however, few studies have evaluated the difference in complication rates or operative outcomes between groups having HIPEC with IDS versus IDS alone. Furthermore, many studies have shown that HIPEC benefits are counterbalanced by marked toxicity and prolonged hospitalizations. To address this, we sought to compare clinical experiences, operative outcomes, and adverse events in these patient groups. We conducted a retrospective cohort study to evaluate patients who underwent IDS with or without HIPEC for advanced stage ovarian cancer at our institution since 2014. All patients received neoadjuvant chemotherapy. We also evaluated multiple intraoperative and postoperative clinical measures and compared them between the two cohorts. To evaluate these comparisons, we used the variables described here. From the first table, we can see that we had 37 total patients, 19 who received HIPEC and 18 who received IDS alone. Groups were compared to evaluate common surgical demographics, which are shown here. No statistical differences were seen in any of the categories on this table. In this next table on top, we see that the surgical complexity score was comparable between groups. However, the HIPEC group had statistically significant longer ICU stays, hospital stays, and length of surgery. The difference in the length of surgery can be explained by the 90 minutes necessary for the administration of HIPEC treatment. HIPEC patients were also found to have less intraoperative blood loss. Hospital readmission was rare in both groups, and in fact only occurred in just one of our patients and was no different between groups. Despite the differences noted in longer hospital stays, there were no differences in between groups for time to receiving follow-up treatment with adjuvant chemotherapy, averaging about 4 weeks for both groups. When we looked closer at ICU admissions and hospital stays over time, the graph in the lower right corner shows a trend in both of these variables in the direction of IDS alone. Our original protocol for treatment following surgery was based off the New England Journal article's recommendations. However, the protocol has been adapted over time at our institution. Other data is not shown, but other variables such as days of nasogastric tube placement following surgery has also decreased over time. The table in the lower left shows that the groups were comparable when evaluating postoperative complications based on Clavien-Dindo classification of adverse events, where all p-values were greater than 0.05. Grade 3 events or above were rare in either group, with just one patient in each group experiencing a more serious complication. In conclusion, our results show that HIPEC is well tolerated. Readmission rates, complication rates, and severe adverse events are rare and comparable between groups. While HIPEC patients have longer hospital stays and ICU admissions, as our center gains experience doing this surgery, we find we are approaching the time frame similar to IDS alone, and these patients do not experience delay to treatment with adjuvant chemotherapy. Considering these outcomes, we plan to further refine the pathway for enhanced recovery after surgery for patients undergoing HIPEC with IDS, and in the future, hope to further evaluate the long-term disease outcomes between groups. Thank you.